This Cincy Lifestyle Health segment, sponsored by Mercy Health.
When it comes to lung and esophageal cancer, early detection is the best defense. At Mercy Health, Dr. Costanzo DiPerna leads a team using screenings, surgery, and cutting-edge therapies to give patients more than just treatment. They give them hope.
My name is Costanzo DiPerna. I'm a thoracic surgeon for Mercy Health at Jewish Hospital. I'm also the medical director for general thoracic and foregut surgery here at Jewish Hospital. It's quite difficult to diagnose early esophageal and lung cancer because there's a lack of symptoms. Most people with early lung cancer don't have symptoms. And that's the same with esophageal cancer. There are not that many consistent early signs. And so we'll talk about lung first, which unfortunately is even the worst cancer when it comes to symptoms that actually give you a sign that you have early lung cancer. You may have indirect symptoms, for example, so maybe a cough, but cough is very generic and you can find those even in the common colds. Same with esophageal cancer. You can have heartburn symptoms, or you can have some discomfort after eating or during eating. That still may not portend any kind of cancer that may be there. Of course, smoking causes lung cancer. Smoking isn't really the thing we should be focusing on. We already know through 100 years of experience that smoking can cause lung cancer and emphysema and coronary disease. But the things I think that we're really more interested in now is, why is it that a woman nowadays who never smoked is now getting more and more lung cancer? And also younger people who have never smoked, or patients that also are exposed to radon, which is the #2 cause of lung cancer. So I think that the issue right now with lung cancer is, what are the real causes? And what are the genetic predispositions that cause lung cancer? And how do we catch it early? The same can be said with esophageal cancer. But the #1 cause of esophageal cancer in the United States is really heartburn, reflux, and obesity. Why do many people who have heartburn and hiatal hernias, why do the majority of them, most of them, never develop esophageal cancer? There are many people who get esophageal cancer who've never had heartburn, who've never had any family history of esophageal cancer. And then how do we screen for them and how do we catch it early? Here at Mercy Health, we have a very organized lung screening program where we have primary care doctors that really help orchestrate the process of catching lung cancer early. And I think that's very important. We have our pulmonary doctors, we have thoracic tumor boards, nodule boards, of which I'm a part of, that we help really screen those patients and then find the lung cancer early. The #1 thing to remember is that for early lung cancer and for early esophageal cancer, the #1 treatment still is surgery. So if the patient is healthy, they can tolerate the surgery, that's still the gold standard. And then there are all these other treatments that are becoming equally as impressive when it comes to outcomes in curing the patient. For example, immunotherapy, drug therapy, targeted therapy, radiation therapy. Those are all additive treatments to the surgery before or after. And here at Jewish Hospital, we have a wonderful multidisciplinary approach. So a pulmonary doc, an oncologist, a radiation oncologist, a surgeon. This is all part of our comprehensive care. We all give our opinions. It acts as a checks and balances for the best treatment choice. We approach the patient with hope. How do we approach a patient with a devastating cancer? One that relinquishes a lot of hope. We approach it with hope, because without hope, there's nothing. And if you've practiced surgical oncology, or you've taken care of these patients for the last 20 years like I have, you start to see that it could be the worst disease. But if you've gained a lot of experience over the years, you start to see that you cure a lot of patients. That patients, even with horrible cancers, they go on living 15 years, 20 years. There is no reason for a doctor to give a patient some sort of number of days of life. That's sort of old school, and I don't think any of us do that anymore, and that's certainly not part of our approach when we manage cancer patients. What we do is we give them hope, and then we give them options. We don't know the actual course and outcome for these patients. What we do know is that we're curing more and more patients. And that's being honest with the patient. But it's also giving them hope, which, as you know, a patient who has very little hope overall does more in the sort of negative direction. They do poorly than those patients who are optimistic, have a great strategy. Those patients actually survive more as well. Now with newer therapies, especially in lung cancer, which we've made the biggest stride in advances over the last 5 years, we also recognize the fact that some cancers are tremendously bad, but yet we get away with providing outcomes that are incredibly miraculous nowadays.